Welcome back to Mayo Clinic Radio. I'm Dr. Sanj Kakar.
And I'm Tracy McCrae.
People who smoke or use other forms of tobacco are more likely to develop disease and die earlier than people who don't use tobacco at all. While people often worry about what smoking is doing to their health and find it difficult to quit, this is because nicotine is highly addictive and most people don't succeed the first time they try to quit smoking.
But after trying different methods, why do so many people still have difficulty quitting smoking? In this day and age of individualized medicine, could our genes hold the key, Dr. Kakar? Could it be?
Everything else is down to the genes, Tracy.
That's right. Here to discuss is the head of the Pharmacogenetics Lab in the Campbell Family Mental Health Research Institute at the University of Toronto, Dr. Rachel Tyndale. Welcome to the program, Dr. Tyndale. It's nice to meet you.
Thank you. It's nice to meet you as well.
So, is it true genetics plays a role in whether we can successfully quit smoking?
Sure. So in all drug dependencies, there's a large heritable risk or a genetic risk in lots of the different phenotypes. So how much you smoke or how long you smoke for or whether you're able to stop smoking. And the area that we've been focusing on is how to identify which people are responding to the different kinds of treatments in the best way, using principally genomics, but also other demographic variables.
So, Dr. Tyndale, I was always taught if you had to quit something, it's where there's a will, there's a way. You can just simply dial it down and off you go. That's clearly not the case.
No. So no one quits a drug dependency easily, or very few people do. So what we're doing is trying to create the best possible chances for them to quit. So matching the best possible drugs that we have available to the right person. And as you can imagine, people quit smoking at various different points in time. Early January is one key point in time where lots of people quit smoking. So what we're trying to do is identify what works best for them.
So there's a tobacco addiction gene, or what is it that your research is telling us?
Sure. So you can imagine, as you said in your intro, nicotine is the primary psychoactive drug in tobacco that drives smoking behaviors. And there are two biologically obvious places that we look. One, which is that nicotine is broken down in your body or inactivated by a pathway in your body. And so what we found in our early studies was the faster that you inactivated nicotine, the more you smoked. And so that was one of our first sort of biological or genomic influences on smoking behaviors. And then the nicotine replacement therapies are also influenced by this same enzyme pathway. Another biologically plausible and what's turned out to be a useful tool is the nicotinic receptors. So where nicotine binds to in your brain is also genetically variable, and it can also influence how much people smoke, for example.
So when you see patients in your clinic, is there a blood test that you're testing for these genes?
Sure. So we can do it through either genomics, the standard blood or saliva test, and a DNA and a SNP test. One of the other things that we've been working out is how to do a phenotype biomarker. So we can look at, in anybody who's a regular smoker, we can look at the rate of their metabolism by looking at the ratio of some metabolites of nicotine in their body. And so that allows us to do very quick sort of biomarker tests as well. So we can either look at the genomics or we can look at the biomarker tests. And
so if you have the genes or you don't have the genes, how does that affect your treatment?
So what we've done is we've identified that people who are, I'll take the metabolism genes as an example. If people are slow metabolizers, and that's probably 30% of Caucasians, but a much higher percentage of other populations, they have much better quit rates just spontaneously. They respond very well to behavioral counseling, but they don't respond very well to bupropion, which is marketed as Zyban in smoking. So they do just as well on behavioral counseling as they do on the drug. So that would be a drug we wouldn't advise for that population, but they do very well on the nicotine patch. So we would give slow metabolizers nicotine patch by preference.
Well, the pharmacogenomics piece of it is that any medication, recently we had Dr. Keith Stewart on who said he, from this point forward, isn't going to take a medication until he sees how it affects, if he's an over-metabolizer or an under-metabolizer, whether it's a heart medication or thyroid medication, whatever it is. So it makes sense that tobacco addiction medications would affect you differently, but it also makes sense that then tobacco would affect you. Like maybe you're an over-metabolizer of tobacco, nicotine, and an under-metabolizer.
Yeah, so I think you're right. In other areas of medicine, the treatment drugs aren't always also the drugs that you're addicted to. So it's a little bit more complicated, or at least we have drugs in the disease that we're studying as well as in the treatment. So you can see differences between slow and fast metabolizers of nicotine from very early stages of smoking. So we do cohort studies with children, and we can see very different patterns of acquisition and how much they smoke from very early stages of smoking. And then we can see from the first time that we see serious quit attempts in adolescence or in early adulthood, we see that the slow metabolizers can quit more readily. So all the way through smoking history, that variation is affecting the behaviors and the exposure and the subsequent diseases associated with tobacco. But they also, these rapid metabolizers also respond to one of our other drugs, varenicline, very well. And so that's been an encouraging moment, is that they have a lot of things that aren't going for them, but we have now found a drug that's very efficacious for them.
So Dr. Tyndale, your groundbreaking research has focused on smoking. Has it looked at other areas of addiction? For example, now with the opioid addiction that exists in North America, have you looked at that?
Sure. So those of us who work in drug dependence are, of course, very, very worried and very concerned about the opioid crisis. We have large studies ongoing, both looking at who's at risk for becoming dependent with different types of opioids or analgesics that are used, with the hope that we can start to refine pain management a little bit better on the acquisition side, and take care in terms of who's more readily likely to become dependent or get into trouble with opiates. But in the more sort of pharmacogenomic side of it, we again have a small arsenal of treatments, but we're hoping to really optimize those treatments for the individuals and what they've become dependent on.
Finally, what is it that makes you excited about going into the work that you do every day?
Probably the first one would be our students. Engaging people in understanding this area and then getting their ideas and that whole expansion of the next generation of scientists. And then in terms of patients, in drug dependence and mental health in general, it's been a really tough thing to try to find good treatments and to get new treatments, and there's a lot of people suffering, and so it's an area where we're really keen to optimize treatment.
We've been talking about pharmacogenomics and smoking cessation with Dr. Rachel Tyndale. Dr. Rachel Tyndale is a research chair of pharmacogenomics at the University of Toronto. Thanks for joining us, Dr. Tyndale.
Thank you very much for your interest.